Welcome guys. By this video, I am going to explain the basic clinical concepts of acute appendicitis, which is the common cause of acute abdomen. So sit back, relax, and enjoy the show. This is the outlines, the introduction, definition, etiology, clinical features, differential diagnosis, investigation, and management principles will be covered as far as possible. This is the anatomical background of small intestine and large intestine, including the appendix. Uh, as you know, the small intestine is the primary site of nutrient absorption, which composed of three different components. The duodenum, which is the first part and the shortest, and the jejunum, which is the mid part connecting the duodenum and the ileum. And the third part is the ileum, which is the longest among the three part of small intestine, and which is the final part or the third part. And the large intestine composed of four different structures: the cecum, the colon, the rectum, and the anal canal. The cecum is it is as a pouch-like structure which is originates around or near the ileocecal valve. It is a site where the appendix originates. And the colon has four structures: the ascending colon, the transverse colon. As you see here, it is second part, the descending colon and sigmoid colon, and the rectum and anal canal here. So the appendix is a mid-gut organ. As you know, the primitive gut or embryonic gut, during gastrulation, the embryonic gut gives rise to three components: the foregut, the midgut, and the hindgut. So the appendix is part of the midgut, and it is first identified at 8 weeks of gestation as a small outpushing of the cecum. It is a finger-sized lumen that extends from the cecum. So clinically, appendicitis it is generally caused by an obstruction in the lumen, which in turn leads to swelling, ischemia, and bacterial invasion. Now let's see the arterial supply of the appendix. The ileocholic artery, one of the major named branches of the superior mesenteric artery, gives rise to appendiceal artery, which courses through the mesoappendix. As you have said it previously, the appendix is a midgut organ, so structures of the midgut are supplied by the superior mesenteric artery. So, as you know, the abdominal aorta gives three anterior divisions of the artery, which supplies the visceral structures: the celiac artery, which supplies structures of the foregut. Uh, the superior mesenteric artery supplies the structure of the midgut, and inferior mesenteric artery supplies structure of the hindgut. So the midgut, as we have said, appendix is midgut. It is supplied by branches of superior mesenteric artery. The lymphatics, the mesoappendix also contains lymphatics of the appendix, which drain to the ileocecal nodes along the blood supply from the superior mesenteric artery. The size of the appendix is variable, which differs from which differs from individual to individual, but the length ranges from 5 to 35 centimeter, and the average is 9 centimeter in adults. Now let's see the epidemiology of appendicitis. Appendicitis occurs most commonly in 10 to 19-year-olds, which means it is during the second decade of life. Overall, 70% of patients are less than 30 years of old, and most are male. So you have to remember that appendicitis is commonly affects male, and it affects between the age range of 10 to 19 years of old or the second decade of life. One of the more common complications and most important cause of excess morbidity and mortality is perforation of the appendix. As the obstruction progresses, the arterial supply of the appendix will be affected, which results tissue ischemia and consequently necrosis. So the structures or the components of the lumen, the appendiceal lumen perforates, and results dissemination of the contents to the peritoneal cavity, which end up with GI focus sepsis, and the patient results pays or results excess morbidity. So perforation is one of the most common cause of excess morbidity and mortality. Now let's see the etiology of appendicitis. Its etiology still not completely understood, but fecalis or but the explained mechanisms are fecalis incompletely digested food, reside lymphoid hyperplasia, intraluminal scarring, tumors, bacterial virus, and inflammatory bowel disease all have been associated with appendicitis. All these etiologies are associated with obstruction of the appendix, which finally leads to appendicitis. This is a relative location of the appendix, even though it is different from region to region or country to country. But the average location, the average population location of the appendix is around 64%. It is retrocecal, around 32%, which is pelvic, and the other subcecal, preilial, and postilial. So the location of the appendix determines the signs and symptoms of the patient's presentation. The clinical feature, abdominal pain, which is initially the periumbilical pain, as we have said, the appendix is a visceral organ innervated by visceral nervous system or visceral nerves, which is poorly localized. Uh, and later, when the inflammation or when the obstruction progresses, uh, it results in inflammation of the parietal peritoneum. Then the pain will be localized to the right lower quadrant. So the pain is patients with appendicitis, their abdominal pain is initially poorly localized periumbilical abdominal pain and later progress to the right lower quadrant, which can be pointed by the patient in the right lower quadrant. The other symptom, anorexia or loss of appetite, constipation, diarrhea, fever, nausea, vomiting. These are the common symptoms of appendicitis. The other signs, abdominal tenderness, right lower quadrant tenderness, rebound tenderness, rectal tenderness, especially in patients with pelvic appendix, cervical motion tenderness. It is also pelvic appendix, rigidity, so sign, obturator sign, rotating sign. These are the signs of appendicitis. This is a classic signs of appendicitis in patients with abdominal pain. There are three maneuvers which can be performed by the physician and have their own respective findings. Rising sign, palpating the left lower quadrant causes pain in the right lower quadrant. Obturator sign, internal rotation of the hip causes pain, suggesting the possibility of inflamed appendix located in the pelvis. And there is iliopsoas sign, extending the right hip causes pain along posterolateral back and hip, suggesting retrocecal appendicitis. These are the selected maneuvers with respective findings, suggesting the specific location of the appendix. Now let's see the differential diagnosis of appendicitis. Acute gastroenteritis, intussusception, myocardial diverticulitis, inflammatory bowel disease in male, testicular torsion, nephrolithiasis in urinary tract infection or UTI. In women of childbearing age, ruptured ovarian cyst, endometriosis, ovarian torsion, ectopic pregnancy, pelvic inflammatory disease. So if the patient presents with symptoms of abdominal pain, nausea, vomiting, abdominal on physical examination, if he has fever, abdominal tenderness, so we have to suspect all these listed differential diagnosis and do accordingly or do investigations accordingly. Welcome back. So far we have seen the definition, epidemiology, etiology, differential diagnosis, and clinical features of acute appendicitis. Now let's see how to reach the diagnosis of acute appendicitis based on the given history, physical examination, and other diagnostic modalities like imaging. So now let's see clinical diagnosis of acute appendicitis. The modified Alvarado scale assigns to a score to each of the following diagnostic criteria. There are three parameters from the symptoms of appendicitis, and there are four parameters from the signs of appendicitis. From the symptoms, migratory right lower quadrant pain, which have 1 point, anorexia 1 point, nausea or vomiting 1 point. From the signs or from the physical examination findings, tenderness have 2 points, tenderness in the right lower quadrant, rebound tenderness in the right lower quadrant 1 point, fever above 37.5 degrees Celsius has 1 point, leukocytosis of WBC, which is above 10 times 10 to the power of 9 per liter, which has 2 points. So among these parameters, leukocytosis of WBC above 10 times 10 to the power of 9 per liter and tenderness in the right lower quadrant has 2 points. So for the interpretation purpose, we have to sum up these parameters and we will interpret and manage our patient accordingly. A score of 0 to 3 indicates appendicitis is unlikely and other diagnosis should be pursued. We have mentioned or we have listed differential diagnosis for acute appendicitis. So if the score is below 3 or 3 and below, so we have to suspect as a differential diagnosis. And if the score is 4 and above, indicates that the patient should be further evaluated for appendicitis or should have other diagnostic modalities to reach the diagnosis like imaging. A score above 7, which is high likely appendicitis. The maximum total score is 9. Previously, the score was out of 10. Now left shift is removed or it is rejected. The original Alvarado score includes left shift as additional factor, resulting a total score of 10. Now it is modified and the total score is out of 9. The other diagnostic modality is imaging. There are two important imaging modalities to reach the diagnosis of acute appendicitis. These are ultrasound and CT scan. So plain films of the abdomen or plain abdominal X-ray are rarely helpful and so are not routinely obtained unless the clinician is worried about other conditions like intestinal obstruction, perforated viscous, or urolithiasis. So unless you suspect this differential diagnosis, you will no longer order abdominal X-ray. The other is ultrasound. Ultrasonographic findings suggestive of appendicitis include wall thickening, an increased appendiceal diameter above 6, because the normal diameter of the appendix is less than 6 millimeters. So if the diameter is increased above 6 millimeters, the likelihood of appendicitis is high. The other probe tenderness, when we apply a probe on the site of on the location of the appendix, our patient feels pain, which means tenderness. The other, the presence of free fluid in the peritoneal cavity or in the site of the appendix. Note that an easily compressible appendix less than 5 millimeters in diameter generally rule out appendicitis. So we have to perform other investigation modalities and you have to suspect other differential diagnosis. This overall sensitivity is 86% with specificity of 81%. Generally, ultrasound and CT scan has a good specificity and sensitivity for the diagnosis of appendicitis. CT scan suggested findings on CT examination include a dilation above 6 millimeters with wall thickening. The lumen that does not fill with intercontrast. We have said that appendicitis results from an obstruction. As obstruction progress, it completely blocks passage of intercontrast distal to the obstruction. So the intercontrast does not fill the lumen. This is a finding of CT finding of acute appendicitis. The other fatty tissue surrounding or air surrounding the appendix, which suggests an inflammation. So if you find 3 findings On CT examination, the likelihood of appendicitis is very high. The sensitivity and specificity of CT at least 94% and 95% respectively. Now, how to manage our patient? Let's see how to manage our patient. Once we reach the diagnosis of acute appendicitis, let's see how to manage our patient. Appendectomy is definitive management or removal of the appendix. A surgical procedure which removes the appendix is called appendectomy, which is the definitive management of appendicitis. All patients should be fully prepared for surgery and have any fluid and electrolyte abnormalities corrected. Either laparoscopic or open appendectomy is satisfactory choice for patients with uncomplicated appendicitis. Underline the term uncomplicated because if it is complicated, our choice of management differs. Management of those who present with MS representing a phlegm or abscess can be more difficult. Such patients are best served by treatment with broad-spectrum antibiotics, drainage if there is an abscess above 3 cm diameter, and parenteral fluids and bowel rust if they have appeared to respond to conservative management. Then the appendix can be removed easily and safely after 6 to 12 weeks later when inflammation is subsided or damaged. So we have to manage our patient the first 6 to 12 weeks by broad-spectrum antibiotics and subcutaneous drainage of the abscess. If it is above 3 cm, then once the inflammation is subsided, we'll do appendectomy. Laparoscopic appendectomy now accounts for the majority of all appendectomies performed in the Western cultures, and it is associated with less post-operative pain, shorter lengths of stay, faster return to normal activity, and likely fewer superficial wound complications. Also, the risk of intra-abdominal abscess formation may be higher. Uh, Thank you guys. This is references where the contents have been taken. Harrison Principles of Internal Medicine, 21 first edition. Up to date Shaw's Principle of Surgery substance. So this is all the contents or the basic concepts of acute appendicitis. Thank you guys. Have a nice time and reading.